like I said, welcome everyone. This is the Value-Based Healthcare Industry Special Interest Group. It's great to see so many familiar faces, and I think, you know, we're starting to kind of, as those interested in value-based healthcare around innovation and industry, I think for me, definitely seeing the same, you know, familiar faces coming through, which is really good. And I think it just demonstrates us kind of learning together and moving forward with this together. And I think that's a really good place to be in at the moment. From an updates point of view, for those who didn't see the Value in Health Week stuff that was taking place last year, it's very, you know, it's worth going back to that, and all the links are on the Value in Health website. There's some really good kind of all the sessions are there now, so it's definitely worth going back to it if any of you didn't get the chance to see some of that stuff. So I'd recommend it. And as you all know, you know, the value-based healthcare space is a developing space, and there's things happening all the time. But, you know, hopefully building this community will allow us to kind of keep a bit more kind of track of that, definitely in Wales, as we move forward as a nation with a big interest in it. So I'm going to start and really crack on, really, because I want to, you know, I don't want to take any more time from you than is needed, and I'm going to hand over to Dee, and I'll let her introduce herself. Yeah, I'm just gonna let Dee introduce herself because most of you know her and I do. So yeah, over to you, Dee. So if you need us to do anything in the background, just let us know. Okay?
No, that's fine. So hi everybody. As promised, I am back. I am now head of value-based healthcare at Morgannwg University Health Board. So left the hub and started over at CTM in September. It's been quite a journey, as you can imagine. It's quite difficult times. And CTM was literally at toddler stage with value-based healthcare. So I've really spent the last few months working in a very complex organisation and very complex situations with COVID and backlogs and everything else we're experiencing, but really trying to find out what was already going on, where did we need to go, and then coming up with a plan, which is what I really wanted to share with you today. It's really great to see some of you again. I have met with some of you since I have gone to the dark side or the light side, whichever way you want to put it. And it's great to see some of our value-based healthcare project team colleagues from CTM on here as well. So hi Shock and Mike and others, great to see you. So I'm going to share with you literally a hot off the press presentation that I've put together that really demonstrates where we've got to in CTM and where our plans are moving forward. So I'm going to share my screen. I'm not going to be able to see any of your faces or raised hands or anything else. So if you're all happy to, if you want to jot down any questions or anything you want to ask me, and we'll have a session at the end to do that. So I'm going to share my screen and let you know where we've got to. So just give me a moment. Okay, can everybody see that? Yep.
Yeah, looks good, Dee.
Fantastic. Okay, so just in general, over the past few years, CTM has experienced significant change along with quality and leadership challenges, and this is really in addition to the recent COVID-19 pandemic. The Health Board has recognised both the risk and opportunities that these challenges present, and in response, a programme of full organisational development is underway, aiming to embed the culture, leadership and capability necessary for securing the future goals and ambition of the organisation and ultimately achieving the exemplar status that it envisions. And this at CTM is being called CTM 2030, Our Health, Our Future. These on here are our aims. This is a key area of work, and the 5 key areas: starting well, growing well, living well, ageing well and dying well, that we're all working to. So within that context, in early 2021, the Health Board implemented a new directorate called ICTM to ensure robust improvement, innovation, value-based healthcare and change function actually existed across CTM to support and facilitate service and quality enhancement throughout the organisation, and enable it to build the change capability needed to meet the strategic objectives and future vision. The ICTM Directorate builds capacity for change across the organisation. So we're corporate based, and coordinates the improvement and innovation activity, engage with staff, patients, community and partners in driving the adoption and spread of the most impactful improvement and innovation options, all underpinned by the principles of prudent and value-based healthcare and co-creation. And I think this is a really big step forward in bringing all of these areas together, and rather than having them in separate functions. What we're also talking about is how do value-based healthcare principles come through an innovation and through an improvement, and then how does the Change Hub help to build that capability and skills with the staff in operations. As we know, projects and having worked at the Hub and with many of you guys, start as an innovation, a test of a concept, but then how do we roll that out wider? How do we look at the metrics and measure the change and evidence that, so that we can get sustainable funding and wider spread adoption of those innovations and improvements? So as for value-based healthcare at CTM, this is Sally May. She's our Executive Director of Finance and she's our executive sponsor of Value-Based Healthcare. I'm head of Value-Based Healthcare. I now have a team. When I started in September, it was just me. But from January, I now have a head of finance and value who will help with costings and reviewing our whole costing profile to look at where there's low value, high cost care and identify strategic priorities for the future to look at. But also, as we're working through our projects, really looking at how do we actually repatriate any savings and efficiencies back through the system, back to where in the project the actual changes have been made, so we can actually fund them sustainably. So our vision, as it says there, working collaboratively across the health board and partners to develop the strategy and plan to deploy value-based healthcare across the whole system. And the whole system is really important. Value-based healthcare, as we all know, has grown over the years, but very much like innovation, sometimes it can be in disparate projects in different areas. And I hope as I demonstrate through the presentation, we're really keen that we have a whole systems approach. So we actually look at the whole pathway and the improvements and innovations that can be put in place through the pathway jointly through different sections of it to improve the whole journey of the patient and the outcomes that we seek to achieve, as well as really understanding the real pathways and the resources that are being used so that we can effectively use them, but also monitor those impact. So this slide shares our outcome aims, and these are within our delivery plan, the ICTM delivery plan that's just been agreed. And it really covers 3 areas. And the first area is the workforce, making sure they're educated, motivated, and that we're really taking forward that golden thread of value-based healthcare in all areas. Digitally enabled, so the fact that we can actually have a digital system that is integrated with our own systems and with systems nationally, so that we can collect, analyse and use PROMs and PREMs. We're also looking at CROMs, so clinical reported outcome measures, and workforce reported experience measures, so that we can really look at how the impact of using this data makes a difference between the clinician and the patient relationship. So REMs are something that myself and John started talking about when we were at the Hub, and we've mentioned them previously. We've actually implemented a trial on this now in our heart failure clinics, which is going down really well. CTM are really keen to make sure that our workforce are involved in all of the changes that we make. So by asking them how using a PROM or a PREM influences their clinical decision making shared with patients, really make sure that it works for them, and if it doesn't, what can we do to make that improve? And I think another key area is how we will actively measure the cost and outcome data to prioritise area, but also implement those high value interventions that are aligned to our population needs, really looking to reduce unwarranted variation in equitable delivery and outcomes and low value care. So this one's a bit busy. This is actually, I've taken this from the delivery plan that I've just written. It's over the next 3 years. It's very summarised, and it's just got some of the key areas that we will be looking into. The key areas really are how do we move from toddler stage at least up to the stage of other health boards? And of course, having Paul Mears as the national lead for the national CEO lead for value-based healthcare, and the fact we host the central team, there is a lot of responsibility on these and my team's shoulders to actually move into a really good place where we're driving this work and being exemplars as well. So we talk about the golden thread, which here I've put into the DNA thread. We really need to make sure that we are socialising and educating around the principles of value-based healthcare. So you'll all be aware of Value-Based Healthcare Academy. Part of my role is making sure that staff have access to those courses, the same as you do, and really enable that industry and health joint learning. But also, how do we build that into our training and leadership courses that we're currently developing and implementing at Value-Based Healthcare, so that it does go through our aims and our culture and becomes the way we actually do things. The collection and analysis and use of big data is absolutely key to ensuring we can describe how the data is collected and how it's used. I'll be diplomatic. It really doesn't matter how many proms we collect, it's what we do with the data. Yes, integration is absolutely key, but if we're sending out 1,000 and we get 100 back, okay, but what are they actually telling us? How do we use that information that is collected pre-intervention and post-intervention to demonstrate whether that intervention worked for that patient in that clinical time? So we're really looking at making sure we get real-time data that is accessible by clinicians and it's used in those sessions to have a real up-to-date conversation with the patient about what works and what doesn't work. But also, if a prom collected post-intervention highlights that a patient really isn't reacting well to an intervention, that we can pull them back in and see them if we need to. And the same with our experience measures. You know, we're linked into our Have Your Say colleagues and our Datex colleagues, how we pick up complaints and issues that are raised, so that we can actually prioritise these through our system, so that it's not just a patient filling in a survey, it's actually something that we can work with. So that's at the personal level, but then how do we use that data at a service review level as well, and also at benchmarking across CTM? So we have 3 integrated locality areas that are almost 3 mini health boards, each with their own kind of priorities and consultant ways of working, makes it very complex. But how do we optimise pathways and reduce that inequity? And we can use that data in that way. And by making sure that data goes into the national data resources and those links, we can make sure that we can benchmark across other health boards and internationally as well, and that will help us learn from them and continuously improve our service delivery. So since I went in, and this was probably about October time, we had 2 papers that went to our board around our vision and our principles for value-based healthcare. And these were the key areas, and our key WP stands for work plan area, so that we could actually look at an integrated approach. So these are the key areas around culture, behaviours and knowledge, skills and understanding. And then the work plan pertains to the education, support and training. So as I was just saying, how do we build that right in for when a job description goes out, through an interview, through a PDR, induction training, and then up to expertise level to actually use the data, undertake financial costings or review pathways. And what behavioural insights do we need for those to actually take place? Communications and engagement. Value-based healthcare, as we know, can all be a bit fuzzy sometimes. It's a new buzzword. A lot of it is common sense and good programme management and reviewing the difference that things make from the as-is position to the optimised position. But as we know, all of those steps don't always get taken. So how do we communicate when projects are taking place, and how do we actually get people engaged and motivated? There wasn't really a governance structure. We had a bit of a value-based healthcare project group that interested people came to, and I'll demonstrate in a bit the governance structure that we've now finally put in place. Our team can't be everywhere doing everything. We have key strategic priorities, which I'll go through, but we also want to make sure that we've got toolkits and support for those areas that are enthusiastic and driving change and driving innovation, are able to use and access, so that the value-based healthcare can actually be mainstreamed. So this isn't always about our team being involved in everything. It's about providing support and guidance through our IMTP in those key areas to really drive those forward as well. We mentioned about the data and the digital integration. It's not just getting the data, the digital integration can be time consuming, it can be very difficult. Getting the data out can be very difficult. We have lots of data providers. So how do we actually get that alignment? And how do we build that then into our signal management for the future and our outcome frameworks? And as I mentioned before, finance and procurement, how do you look at the review cost of our care? How do we look at what we're already commissioning and contracting? How do we look at outcome-based contracting for the future? So I mentioned that I'd put in place a governance and assurance structure. This looks pretty heavy, so I'm going to take you through it. It's more the fact of, and I'm sure you've all experienced this, either where you currently work or have come up against it in health before. But when I started, there were about 15 business cases for heart failure projects related to value-based healthcare, all through the pathway. But they were disparate and they were separate, and none of them were linked or understand the link into each other, or the impact onto each other, which can often cause bottlenecks. So what we've done, earlier last year, an Improvement and Innovation Board, the IIB, was established, which feeds straight up into the executive boards. And there we consider all of the innovation improvement of value-based healthcare. I've established a value-based healthcare steering group, which includes Sally May as chair, but then representation from our executive team, also our integrated locality group directors and our strategy group directors as well. So the function of that team is oversight of the programmes that are taking place, and I'll come on to the fact that money has also been allocated to health boards through the Value-Based Healthcare Fund as well now, so they will also oversee our funding of our projects. Underneath that, to have this whole systems approach, as you can see, we've got a heart failure value-based healthcare steering group, one for well legs and well healing, and that's around lymphedema, cellulitis, and other work that we're doing around wound healing and pressure ulcers. Got a diabetes steering group and a whole integrated plan under there of areas of work, and key areas around finance, procurement, and digital and data. But underneath the specialty groups, as you'll see, so I've only highlighted the heart failure one here. We start at self-care, so this is some project work that's taken place out in primary care, a WISE programme with wellbeing consultants that can help optimising patients in the community. There's a lot of patients who health has deteriorated due to COVID and access, so we're doing work there, and that's across cardiology, diabetes, mental health. But we're putting in PROMs and PREMs and really monitoring that and working with primary care to see how that work can support patients in their communities, but also the impact that might have on reducing admission rates or reducing ED rates. So linking that through optimising diagnosis, another project that we're doing with industry partners who are on the call, so with Roche Diagnostics and with DigiFarm, optimising our treatment work stream as well, rehabilitation workstream and palliative care workstream. So all the way through, there's actually a governance structure in place now. So previously we'd have a disparate business case, there would be no programme management, there would be no benefits realisation, there would be no measurement. So consistent approaches to programme management, reporting, and all of that has actually been put in place. So all of that governance structure has been put in place now. So as I said, we were at toddler stage, and the FDU, the Finance Delivery Unit, developed a value-based healthcare maturity matrix that they've asked all health boards to complete. So I'm sharing this with you. This is still at kind of draft stage until we get to our steering group in March. But I undertook one in October just to see what was I up against in coming into value-based healthcare at CTM. So I knew we had interest at leadership level, with Paul Mears as the lead. Kelechi was then the executive lead, really good links with population health. I knew that work had been done to identify the strategic priorities of cardiology and diabetes, and I knew that work was starting to be done around culture. it was just me, and as I said, the team has started to come in play now. We've now got a program manager, data and digital manager, and we will have a finance costings lead and a data analyst, hopefully starting with us soon as well. So what I redid it in February, really just to see how much has moved, in the fact that we didn't have much governance, we didn't have any program management, we'd only just started a bit of problems collection. So there's been some slight improvement. This is a real honest representation of where we are. Some of the questions in the maturity matrix could be seen and could be answered in a more general way. You know, do you involve patients in your work? Well, if we're talking about value-based healthcare, no, not at the moment. But if I was talking about CTM, it would be a yes, and we'd probably be at 25, but it wouldn't be a real representation of where we are. And I'm really keen that we really demonstrate our growth as it actually happens. So we'll be sharing this with our steering group, and we will be using this as a way of focusing our work and where our key priorities are and the movement we actually have on that. And then we will be reporting that to the FDU on a 6-monthly basis. So as I mentioned, the £20 million actually came out for value-based healthcare, announced and allocated to start from the beginning of the new financial year. There's been a split of allocation across all of the health boards. Ours is just under 2.3 million, 2.3 rounded up, and then 5 million will be going to the National Centre for Value in Health. So I've literally been working with our teams and across CTM to really look at where did we need that financial investment. There was guidance that came out from the FDU that we've matched. There were some great practice projects that had already been taken place and proven in other areas. So these are this is our split at the moment, and this is what will be going to our steering group this month to sign off, and then to commence in April. So within CTM, there's already some infrastructure. So as I mentioned before, the dedicated value-based healthcare MDT team, executive sponsor, we've now got support from an assistant medical director through the innovation team. The public health and population health team are doing an amazing area of work in diabetes segmentation work that will really help all of us to further understand the impact of diabetes and to support future planning of services. Our information and clinical team support, and as I mentioned before, our problems platform and ICT integration support. Our actual programme support then, our specialty areas that we're going to be progressing with this funding are the projects around heart failure, diabetes as listed there, lymphedema phase 1 and 2, cellulitis, the alcohol liaison service project, and there's a number of other projects that are literally just developing their business cases now to go to the steering group as well. And we're hoping that the Humour app in cardiology will be one of those that we take forward, and a value-based healthcare chatbot with Respiratory Innovation Wales. What that also leaves us with is some unallocated funding, which we want. I wanted that for some flex, so that we're able to be agile as new projects or new ideas come forward during the year, that we're able to then support. So we're currently just putting in place those prioritisation and business case processes to make sure that that funding can be quickly bid for and put out. The projects here will be supported on a 2-year basis, but I guess it's fair to say, and I mentioned this to John earlier, and I don't mind it's going down in history of saying it, but I've pinched the Spider-Man line, which is with funding comes great responsibility. So what this funding actually enables us to do is embed a consistent programme management and reporting approach, embed benefit realisation approach that means that those metrics and proms and prems get used as evidence as to whether these projects and programmes of work do deliver high value care. So that through the time frame and at the end of the time frame, we have that build up of evidence to how we can then repatriate the efficiency savings or cost savings through the system back to financially and sustainably fund these areas. Or if they're not working, that we can demonstrate that, and we actually have the evidence for why we would withdraw. So that was those. So just quickly a closer look at heart failure. It's one of our key specialty areas, and really to demonstrate what we mean by this whole systems approach. So we're developing the strategic priorities in an integrated way, which considers the patient journey through our system. And as I mentioned, for too long, silo improvement projects and resource funding within the same pathway have been disjointed with the unconnected business cases and unconsidered impacts, and at times creating bottlenecks and wider delivery issues. So we've established the multidisciplinary heart failure value-based healthcare steering group with membership throughout the pathway from primary to palliative care, with consultants and GPs and allied health professionals right the way through. We've held workshops reviewing the current pathways, looking at the inequitable service delivery and patient outcomes to determine these key strategic areas and interventions which will improve the patient outcomes. And actually, as part of our optimising diagnosis project, Roche Diagnostics, and Shock's on the call, so I've got to give kudos to Shock because he's been doing fantastic work with our consultants, with our heart failure nurses, to establish the real life pathway in each of our ILG areas. So not the nice pathway, not the pathway we all think we're doing on paper, but the real pathway and the real barriers and the real issues and the real work that people are taking on top of other work. So for example, funding was given for heart failure nurses on a very short-term basis, but no admin support. So actually a lot of the clinical time is taken up doing the clinical, doing the admin work because nobody thought to put that in the business case and provide it. That then has an impact on how many clinics they hold, how many people come through, the motivation and inappropriate use of clinical time. But I think that really demonstrates the power of industry and health boards working together in a really great relationship, and it really is a good relationship to help us to unpick and unpack that, so we can then look at what our optimized pathways can be and what do we need on those to move forward. So there's a little bit more detail here. Now, as I mentioned, they were all quite disparate business cases. Their benefit realization in a business case basically said what's on the other side, right? They put a target outcome, but there's no numbers. So for example, the optimization of treatment, so using heart failure nurses, was going to it was going to increase diagnosis, was going to reduce the days it takes to optimize medication, it's going to reduce length of stay. However, there's no idea of how much it was going to reduce length of stay. So we're really working with them now on the so what of each of these projects. What are the metrics? Where's the data come from, and how are we actually going to measure that? And the same here. So the rehabilitation project is actually a new project. This is really, as it says there, maximising nurse-led education element. There's elements of psychology. All of our allied health professionals are involved. How do we increase that appropriate referral, move care closer to home? So what rehabilitation appropriately can be done at home, prehab and rehab, and how do we link that with the local authority resources as well? So really keen to get this going. It's a new pilot for CTM. It'll be across 2 of our areas. Palliative care, we implemented the Cardiff model, the value-based healthcare project, in 1 IOG. We've already identified the benefits, so I'll be funding rollout across CTM, and then really looking at that benefit realisation element of that. I thought I'd share this with you because what did I say earlier? So PROMS collection isn't about how many you've sent, but it is how many you send and how many people completed them, right? The uptake rate is important. Of course it's important, because if you're sending them out and people don't bother to complete them, that can, you need to work out what your communication issues are. But also if people are completing them but nothing is done with the data, then that puts us in a really difficult position. 1, from a DPIA point of view, you don't collect any data you're not going to use. And 2, if patients are telling us really important information and we're not acting on it, 1, they won't do it again, and 2, we're not really delivering that high value care that we said we would. So we literally only started collecting PROMS data in heart failure in December. This was our January data. So I think around 30 to 40% is normal. So we're on par here. But as I say, this was just in 1 clinic just to get us going. We've now rolled this out to the other clinic areas. Not been without some difficulty, because obviously we had the repatriation of Bridgend back to us, and their data was still going on the Swansea data system. So, any of these things are never easy. But the National Centre actually developed the national standards guidelines for prom providers and proms provision for health boards, and for that data to go in centrally. Cardiff and Vale tested that last year and have appointed a new proms provider. We will be undertaking very shortly a procurement exercise. I have been linking in with Saeed, and in case any of you aren't aware, there is a national PIN notice out at the moment for any interested proms providers to get involved, and a workshop has been planned for next Thursday, the 10th of March. If anyone is interested, drop myself or John a line and we'll make sure that you've got either Saeed or shared services details so that you can get involved in that as well. There's been a number of interested parties. There are also a number of interested health boards. So CTM, we are looking to procure, Betsy is looking to procure, Powis is looking to procure, and I understand Swansea and AB are currently in contract, but with contracts that will be ending at least within, I think, Swansea are this year and AB is next year. But we all need to meet these national guidelines. So it will be really interesting and really exciting to see the data that comes through there to really help us support the patients and the clinicians better. So you'll be glad, and my voice will be, that I'm almost at the end here. So, you know, we're really pleased that the funding has come out to be able to get CTM up to the position of taking on some of the projects that have already been demonstrated in other areas. But I'm really pleased that I'm doing that in a whole systems approach, as I've demonstrated, through a pathway. But there are some areas where we feel that we're leading the way as well. So I mentioned quickly earlier about the work that our population health team are doing on diabetes. So we're currently using access through SAIL to the historical integrated data on CTM populations, and really going to be looking at the scope of that data of diabetes in primary and secondary care to help us understand what's happening there, and link that, see how that data can also be linked to the new value-based healthcare diabetes dashboard, and see if that helps us with the picture of diabetes in Wales. The project that I mentioned earlier, the optimising diagnosis, as I said, is working with Roche Diagnostics and DigiFarm, and a key part of that project is being able to test the DigiFarm outcome-based procurement platform in partnership with Roche and the contracting of NT-Pro BMP to see how our outcome measures can be fed in and then monitored to see how the contract agreements are actually being met through the use of the product. And this is a test for this area, but obviously there's wider applications for other contracts and suppliers at CTM. So that's a key area to keep an eye out for. And there is a case study that the Hub has helped us with. The Hub, myself and John, you know, John's been continuing the work, are a key partner in this project, and have really helped with the joint working agreement, and really making sure that those liaisons with industry, with your part, you know, with yourselves as partners, can come to us in the health board as well. The My Mobility Trauma and Orthopaedic Prom project. So I don't know if Ruth is on the call, but Ruth was always, you know, a very keen supporter of value-based healthcare at Zimmer Biomet and was a member of this SIG. CTM took forward the My Mobility TNO project in partnership with Zimmer Biomet. We launched 2 weeks ago now. I was on leave last week, so we launched just before I went on leave. We're already getting letters in from patients about what a difference that app is making to their lives. So that app, it enables PROMs and PREMs collections. So we've been able to bring in and link in our PREMs system from CTM, so the system can do the both. But it also has the rehab and prehab and rehab exercise support and direct links in with the consultants. So that's going really well, and we'll look forward to sharing some more information on that in the future. And as I mentioned earlier, really driving forward this work around workforce reported experience measures, and how the use of that, the use of PROMs and PREMs and value-based healthcare approaches, whether that impact that we hope is actually having on those patient relationships and improved care are actually taking place, or if there's difficulty accessing a prom, or the data is not coming through, or it's not flagging, how do we then pick that up and make sure that we can take that forward? So just as my voice is about to go, I'll move us into Q&A. I've just put up there, we do have a value-based healthcare email box that is monitored by my team. So if you want to get hold of us at all, then please do drop us a line at that email address. So I just leave that up for a couple of seconds for you to jot down. But it's vbh.ctm@wales.nhs.uk.
Yeah, wonderful, guys. And just a plug from us, I've been asked by the team, so we've got a new podcast series coming up very soon, which is going to be on the website. It'll be going out on social media and comms, and it's our new Healthy Thinking podcast, which has got some really interesting individuals and discussions that are going to be taking place. So keep an eye out for that. So and you know, I can send out any details that come across when we have them ready for everyone. And yeah, thanks for coming. Like I say, it's nice to see the familiar faces. I think we're getting to know now who's really interested in this and who's, you know, really got an appetite for this. And yeah, and if we can help each other out along the way, and you guys in industry, I think that's the best way to move this ball forward. So yeah, thank you. And yeah, have a good afternoon, and apology for the change around, but there we go. I think we've benefited from the longer discussion options.
Yeah. Thanks, Sean. Right.
Thanks, everyone. Have a good day. Bye-bye.